Hi, this is Shubrook, and now we'll talk about type 2 diabetes. Our learning objectives for today will be to gain familiarity with the epidemiology of type 2 diabetes, gain an appreciation of the multi-system pathophysiology, know the evidence for the prevention of type 2 diabetes, focusing on also the key aspects in the approach of someone newly diagnosed with type 2 diabetes, including therapeutic lifestyle change, self-care, and medications. And then really recognizing the importance of becoming familiar with the necessary components of the comprehensive diabetes management team, including key members of the interprofessional team that are needed to really provide excellence in diabetes care. We'll also want you to be familiar with patient-centered approach to type 2 diabetes, and then understanding the overarching principles of management of type 2 diabetes, including therapeutic lifestyle change, principles of self-care, classes of diabetes medications, the treatment of medications not only for glucose but blood pressure, lipids, comorbidities, and then also necessary psychosocial support. So diabetes has become an epidemic, not only in the United States, but worldwide. We know there are 30 million Americans, approximately more than 9% of adult Americans have type 2 diabetes or have diabetes, and more than 90% of those have type 2, with an estimated somewhere between 1 and 2 million more people being diagnosed each year. In 2015, 1.5 million people were diagnosed with type 2 diabetes. And we know that your risk of diabetes increases as you age, so there's estimated 25% of the elderly population have diabetes. And the other thing that's been a dramatic change recently is the increase in type 2 diabetes in children. Dr. Hendricks will talk a bit more about this, but we now know somewhere between 20 and 33% of children who have diabetes have type 2, and another 7% of children and adolescents have prediabetes, and many of them will go on to develop type 2 diabetes. And then finally, we know that diabetes is an expensive condition. Your healthcare costs can go up by 2 to 3-fold the year you're diagnosed, and currently 1 in 5 U.S. healthcare dollars is spent on the person with diabetes. And we really know a lot about the natural history of type 2 diabetes. I know that Dr. Gugliucci will talk a fair amount about the pathogenesis of abnormal glucose and fat metabolism. But if we look at the clinical level, you can see here at time onset 0 that people will have anywhere from years to decades of abnormality in insulin resistance and insulin secretion prior to the diagnosis of type 2 diabetes. And so early on, if you look at the bottom part of the graph, one of the earliest identifiable findings is insulin resistance. And we know that early on, whether this be from our genetics, whether it be from our endocrine axis, or whether it be from our dietary intake, we become increasingly insulin resistant. And our body has the ability to compensate, and it compensates with early insulin resistance by hyperinsulin secretion. And so you can see early on that you have both rising insulin resistance, but rising insulin levels to match that insulin resistance. But the body cannot continue to compensate forever. And so over time, eventually, we will overcome our body's ability to compensate, and you will be maximally insulin resistant, but your insulin secretion will start to become deficient. What's most important about this is by the time you're diagnosed with type 2 diabetes, you're already maximally insulin resistant, and your insulin secretory capacity is already starting to decline as much as 50% on the day you're diagnosed. Let's go now to the upper graph. If we look at the upper graph, we know that early on, when you have rising insulin resistance and increasing insulin secretion, you can still have normal fasting and postprandial glucose. It's not really until those curves start to separate and you start to get failure of insulin secretion that you'll start to see abnormalities in the glucose. So as much as we know that we can screen for prediabetes through fasting and postprandial glucose, these are relatively late findings, and you can have a decade of abnormalities prior to the time you're diagnosed. And if we wait for our current guidelines and the current screening recommendations, we know that we've already failed both fasting and postprandial glucose. And you've already gone over the waterfall in terms of declining beta cell function and decreased insulin secretion by the time you're diagnosed. So we really need to do something better than we're doing in terms of diagnosis of type 2 diabetes. Next, if you look at what comes along with this pathophysiology, you can see that this is, again, imagine superimposing this graph on top of the one previously. Even prior to diagnosis in your prediabetes status, you can see that you have multiple metabolic derangements and abnormalities, both in glucose and fat metabolism, deposition of fat, and its endocrinologic function. These abnormalities are not benign, and in fact, you can see problems with microvascular and macrovascular disease even before you're diagnosed with type 2 diabetes. This is so impressive that 30% of people on the day they're diagnosed with type 2 diabetes already have a complication of diabetes, such as nephropathy, retinopathy, or neuropathy. Further, many people find out they have diabetes when they have a macrovascular complication. So as many as 25% of people who present with an acute myocardial infarction, or 33% of the people that present for open heart surgery, find out that they have diabetes at the time of that event. Often patients will say that the heart surgery caused their diabetes, but indeed we know the opposite is true. So prediabetes is not a benign condition. The problems from diabetes start even before we're diagnosed, and we need to do our work in a timely way and as upstream as possible. So, type 2 diabetes is a medically complex disorder. We know that there's at least 8 pathophysiologic mechanisms, and that you can't address a single mechanism and hope to get ahead of this disease. We also know that this is a polygenetic disorder. There's more than 100 alleles that have been tied to the pathophysiologic mechanisms in type 2 diabetes. And so there's not a single genetic inheritance. This is changes in chronic metabolism adjusted over time, which makes it much harder to treat. We also know that the family history is a strong risk factor for type 2 diabetes. We talked about in type 1 that 90% of people with type 1 do not have a family history. However, if you look at type 2, a person has a 1 in 7 chance of developing type 2 diabetes if their parent developed type 2 diabetes before the age of 50. The risk is a little bit lower, 1 out of 13, if their parent was diagnosed after age 50. However, if both parents have type 2 diabetes, that child has a 50% risk of getting type 2 diabetes. So we know that the penetrance of these genetic traits is strong. And then finally, we know that most people who eventually develop type 2 diabetes may present with prediabetes before, and that there's a period of time that they'll be in the preclinical state at which we could do something about it. And now we have estimates that approximately 11% per year will progress from prediabetes to type 2 diabetes, and approximately 70% will progress sometime over their lifetime. So how do we find people who are at risk for type 2 diabetes? Well, that really should not be hard at all, because in fact, most of us are at risk for type 2 diabetes. The current recommendations for screening include the following. Any adult with a BMI greater than 25, meaning that they're overweight or obese, or any Asian American with a BMI greater than 23, and have any of the following risk factors should be screened for diabetes. The reason why there's lower BMIs for Asian Americans is that we know that those from Asian descent, and probably from other ethnic backgrounds as well, actually start to develop metabolic abnormalities at lower BMIs. So once you've established that they're metabolically overweight or obese, if they have any of the following risk factors: physical inactivity, a first-degree relative with diabetes, they're from a high ethnic risk group, they have a history of gestational diabetes, history of hypertension or cardiovascular disease, if they have diabetic dyslipidemia, which is the low HDL or high trigs, a history of PCOS, or a history of prediabetes, or the physical findings of insulin resistance, such as acanthosis, we really should be screening them for prediabetes and diabetes. Now, those are high-risk adults. Further, the American Diabetes recommends that all adults starting at age 45 should be screened for diabetes because of the independent risk factor of age. And for both groups, this screening should be at a minimum of every 3 years if it's normal, and if it's abnormal, showing that they have prediabetes, the screening should be moved to annual testing. The United States Preventive Services Task Force, which is a rather conservative group in terms of implementing screening and treatment programs because they focus on cost effectiveness, recommend that we should screen any asymptomatic adult for diabetes if they have a blood pressure greater than 135/80. So you'll find that this in many respects are many adults in the United States. We mentioned the physical findings associated with prediabetes and diabetes. Acanthosis is one of the classic findings, and it really has to do with excessive melanocyte production and hyperpigmentation associated with insulin resistance. We had talked about earlier in the pituitary lecture about how Cushing's disease can also present with hyperpigmentation, as can Addison's disease from a stimulation of ACTH. Truncal obesity is also an important risk factor for diabetes and prediabetes. So we often talk about the BMI as a predominant factor, but we also want to look at the waist to hip circumference. So for those people who are obese, they're clearly at risk. For those that are overweight, their waist to hip circumference can strategize or triage those who are at higher risk for diabetes and those who are at lower risk. So we know that 2/3 of adults in the United States are either overweight or obese. So is it inevitable that someone is going to progress to type 2 diabetes then? Let's talk a little bit about diabetes prevention. And Toro is currently considered a leader in the field for diabetes prevention. So much of this will be review for you. But less than 10% of healthcare providers around the nation still have good knowledge about the diabetes prevention program. So consider yourselves ahead of the curve. So you probably know already that Diabetes Prevention Program study was an NIH-funded study nationwide representing 3,000 adults who are at high risk for developing type 2 diabetes. These were across 27 centers across the United States and really represented a good range of ethnicities, age, and socioeconomic groups. They were intervened with the following treatment regimens. They were given routine care, and that group was told that they had pre-diabetes and they were at risk, or they were given metformin, because metformin was an established treatment for type 2, or they were given an intensive lifestyle intervention. This intensive lifestyle intervention focused on a reduction of fat and total caloric intake, an increase in 150 minutes per week of physical activity, and a total weight loss over the course of the 1 year intervention of approximately 7% body weight. And as you probably already know, the results of this study were profound. The primary results benefited those in the lifestyle arm. We know that those that in the routine care arm were going to progress about 11% per year. When you looked at the treatment arms, metformin had a benefit for the reduction of new onset diabetes with a 30% reduction. But lifestyle had a 58% reduction in new onset type 2 diabetes. And so really this was shown to be a powerful intervention. And one thing that was unique about this study is that the higher the age of the person participating, the greater the benefit they got. So those above the age of 70 actually had, or above the age of 60, had a 71% reduction in new onset type 2 diabetes. And then these benefits maintained for an additional 10 years. So even 10 years after that 1 year intervention, those people that did an intensive lifestyle modification continue to get continued benefits with decreased new onset type 2 diabetes, despite the fact that most of them had regained their weight. So this is not only a weight related factor. And while this was impressive, not much changed in terms of healthcare after the study was published in 2002. But this study was not alone in its findings. In fact, there were 3 international studies, all completed about the same time, that had very similar results. As I mentioned, the Diabetes Prevention Program had a reduction of new onset diabetes of 58%. One of the other measures of cost effectiveness we use is the number needed to treat. In this study, for every 21 people in the program, there was a reduction of 1 new onset type 2 diabetes. There was a similar study done in Finland, the diabetes prevention study, and they saw 39% reduction in new onset type 2 diabetes, with a number needed to treat of 22. And a third study done in China had a 51% reduction in new onset diabetes, with a number needed to treat of 30. And so the consistency of these studies really showed evidence that we can do a lot to prevent type 2 diabetes. And from that came the National Diabetes Prevention Program. So this program has been led largely by the Centers for Disease Control, and basically the goal of this was to implement a community-based approach to reduce the new onset of type 2 diabetes. And the goal of this program was really to have not only a personal health benefit, but to show public health benefits for the reduction of new onset type 2 diabetes. As you know, we have more than 15 cohorts of the diabetes prevention program going on in and around Solano County, as many of you are actually coaching and making a difference in public health. These programs are now all across the country, and you can go to this website if you'd like to see where the closest diabetes prevention program is to where you live. So in addition to lifestyle, we also know that there are medical and surgical interventions that also reduce new onset type 2 diabetes. So there are currently a number of medications, including metformin, if you're overweight or obese, that have benefit to show that you could reduce new onset diabetes by 31%. Acarbose in the STOP NIDDM study also reduced new onset diabetes by 25%. Pioglitazone and troglitazone, or TZDs, they both had very robust reductions in new onset type 2 diabetes and have quite durable benefits, but are used less often because of some of the potential side effects. But there are multiple medications that treat diabetes that also reduce the new onset of type 2 diabetes. And then there's also some weight loss medications, including orlistat and phentermine/topiramate, that also have some reduction in new onset type 2 diabetes. And then finally, we now have 10 years of bariatric surgery, the Roux-en-Y procedure, that people who have prediabetes who undergo bariatric surgery can have a 75% reduction in new onset type 2 diabetes. And the International Diabetes Federation has challenged us to consider weight reduction surgery as one of the primary interventions to prevent and or to treat new onset type 2 diabetes in those people who are obese, because indeed it might end up being one of our more cost-effective treatments. This should be startling and really, in some respects, represents our inability to get control of diabetes through therapeutic lifestyle measures. So there was an article, I believe in New England Journal, titled, "What's Preventing Us from Preventing Diabetes?" And I asked that question. We have simple screening tests for prediabetes and type 2 diabetes. We know that we have effective interventions that can help us prevent people from going from prediabetes to type 2 diabetes. We know that the healthcare quality of life and the healthcare costs are substantial with type 2 diabetes, and they can be largely prevented. And I didn't share this data with you, but there's now good evidence from a Medicare modeling program that this program is cost effective when implemented on a national level. So it's a cost effective intervention for both screening and lifestyle intervention. Yet, we still do not fully engage, and part of that is a lack of awareness amongst healthcare providers. So I want you to remember that that prediabetes is a precursor to type 2. It is not a benign condition, and that many people have complications even before they're diagnosed. We have very good evidence from lifestyle interventions and medication interventions that we can delay or prevent some type 2 diabetes. And what are some of the medications that have been shown to be effective in the prevention of type 2 diabetes? So now we'll move to the presentation of type 2 diabetes. So I'll give you a case. A 54-year-old male presents to you with fatigue and penile candidiasis. Fatigue's been going on for some time. The candidiasis is really what concerned him. Of note, he was at his bus driver physical last week, and he failed the bus driver physical because of glucosuria. He has no known past medical histories other than obesity. He's not currently taking any prescribed meds. He is taking omeprazole over the counter for heartburn that he has if he eats too late at night. He misses smoking cigars, rarely drinks alcohol. In the office today, when you see him, his random blood sugar, fingerstick glucose, his FSG, is 176. His A1C is 6.8%, and his BMI is 38. You get his blood pressure, it's 148/96. And then other than truncal obesity, his exam is otherwise relatively normal. I want you to look at these numbers and vitals to help answer the next question. So does this person have diabetes? And if he has diabetes, what type does he have? And this is an important question to ask. So you need to know what the diagnostic criteria are for diabetes. When we look at the clinical presentation, most people with type 2 diabetes present asymptomatically. They're found at routine testing, or they're found at the time of a complication, or they're found at the time of other medical care. This is in distinction to what we talked about with type 1 diabetes, where most people present with the polys and weight loss. So it's easy for people not to know that they have type 2 diabetes. And as I mentioned, 90% of people with prediabetes don't know they have it. Some people will have nonspecific symptoms such as tiredness, blurred vision, or maybe headaches. If this goes on long enough and the person decompensates, you will occasionally see a person with type 2 diabetes who presents with polys and weight loss. But this is a rather late finding for someone that has gone a long time without necessary treatment. And in the introductory lecture, we talked about the diagnostic criteria for diabetes, but prediabetes is a precursor to type 2. And I want to highlight the continuum between normal to pre to type 2 diabetes. So we have three different ways to diagnose diabetes or prediabetes. We can diagnose via the fasting glucose, we can diagnose by the 2-hour postprandial glucose, or we can diagnose by hemoglobin A1C, which is the glycosylation of hemoglobin over time. So a fasting glucose less than 100 is normal. A 2-hour postprandial glucose less than 140 is normal, or an A1C less than 5.7% is also normal. In the prediabetes range, you have a fasting glucose between 100 and 125, an impaired glucose or post-meal glucose between 140 and 199, or an A1C between 5.7 and 6.4. Diabetes of any type, but we're talking about type 2 diabetes today, is diagnosed with fasting glucose greater than 126, a 2-hour postprandial glucose greater than 200, or a 2-hour glucose tolerance test with a glucose greater than 200, or an A1C greater than or equal to 6.5%. It is important to note that each of these tests have different levels of sensitivity and specificity. And one of the reasons why we've added additional tests is to increase the value of that. So in many respects, the fasting glucose may be a late way to find type 2 diabetes. And we used to use fasting labs all the time to diagnose, but it was actually quite hard to get patients to come in fasting and actually get a true accurate glucose measurement. So having the luxury of having the A1C, which can be done fasting or non-fasting, and now we can do it with a point-of-care machine in our office, we're actually able to get lab values earlier on and get an assessment for our patients. But the other part of this is the true diagnosis of diabetes is typically with repeated testing separated by time. So we usually want 2 tests with at least a week separating them to confirm the diagnosis. So when we talked about our initial patient case, he had an A1C of 6.8, which is diagnostic of diabetes, but his random glucose was 176, which is in the prediabetes range. So while I suspect he has type 2 diabetes, if we're following the academic kind of guidelines, we probably should have a repeated test to confirm this diagnosis. And just kind of for your edification, the hemoglobin A1C has now been linked to helping estimate what the estimated average glucose is, because patients, when they check their glucose, they actually are looking at glucose values. And when you give them an A1C that doesn't seem to correlate with that, it's hard for you and they to understand what the average glucose is. So typically an A1C of 6% is an average glucose in the 120 to 130 range. And then typically for every 1% the A1C goes up, you're adding about 30 milligrams per deciliter of glucose to the estimated average glucose. And so this helps us to let our patients have some idea where they're at in terms of their average glucose. And when we're looking at why a hemoglobin A1C of 6.5 is an important cutoff for the diagnosis of diabetes, we find that About 6.5 is where you start to see a dramatic rise in retinopathy, and it's a meaningful level for which complications will start to arise, and diagnosis would be important. So what are the key topics to address when you're diagnosing someone with type 2 diabetes? First of all, make a clean diagnosis. Don't minimize this diagnosis. Often I will see patients who say they were told they had a touch of sugar or they had borderline diabetes. And while this might be a gentler way to let someone know that they have an abnormality, it doesn't do the patient any favors because their risk of complications and their risk of cardiovascular disease is similar in that prediabetes and early type 2 diabetes range. And so the longer you take to diagnose the disease and the longer you take to treat, the worse off your patient can be. And you're really putting them at risk. You also want to make sure you understand what their conceptions are of the condition. Diabetes is so common now that most people have had an experience with someone they know with diabetes. And you want to make sure that what they know about diabetes is accurate. And then finally, diabetes is a condition that is largely self-controlled and requires monitoring, and it's important to let your patients know what are the numbers that they need to be monitoring when they have diabetes. When we get to the diabetes lab, we'll share with you a sheet that we use for our patients that kind of outlines all the metabolic parameters we manage in type 2 diabetes. And then finally, you want to make sure you develop a proactive plan for your patients. You want to review treatment goals. You must review the benefits and the risk of intensive treatment. And then also remind them that repeatedly that therapeutic lifestyle change is always an important part of diabetes management. And that diabetes self-management education, or DSME, is also critically important to having an active and productive plan. With that in mind, there's so much to teach the patient that you're going to have to stagger this information over time to give them a chance to be able to digest and integrate these changes. I sometimes will bring the graph back up about the progression of type 2 diabetes. So you can see here, I can show the patient that they've been diagnosed, that they have years to decades of abnormalities that have occurred prior, and that this is not something that they were normal a week ago and they're abnormal now. This is something that's taken a long time to develop, and the longer we wait to treat, the more we're putting our patient at risk. So let's go back to our case. Your gentleman who had the glucosuria and penile candidiasis, you gave him a glucose meter, you taught him how to use his meter, you gave him testing supplies, and you said you'd like him to get some further labs to determine if he indeed has diabetes. And you said that there were multiple issues that had to be addressed, but you'd like to make sure you have a correct diagnosis first. So indeed he comes back, and these are his glucose readings. You can find that his fasting glucose is anywhere between 118 and 148. His postprandial glucose or random glucoses are anywhere between 100 and 200. So now you have had multiple fasting glucoses in the diabetes range, and you have at least one postprandial glucose at the diabetes range. So at this point, I think you're certainly able to diagnose type 2 diabetes. Further, you get his labs back, and you can see that he's got classic diabetic dyslipidemia. He's got low HDL and high triglycerides. You can see that he's got elevated transaminases. His glucose, which was fasting at the time, is 138, so it's also diagnostic of diabetes. And then finally, he's got an elevated urine microalbumin of 280. So as a thought question, I want you to think about what additional diagnoses you can add at this point. So your patient, as we move forward to the general management of type 2 diabetes, has type 2 diabetes, has obesity, has likely fatty liver disease, but I think we'll need to do further evaluation of these transaminases. And they have albuminuria, or elevated albumin levels above the normal range, which can be an indicative of nephropathy or an early diabetes microvascular complication. So this patient has multiple things to work on, and you and the patient have your work to be cut out for. So what are the treatment goals for this patient? You're going to want to normalize the blood sugars and hemoglobin A1C. You're going to need the patient to get diabetes education, nutrition education, and dietary instruction. Um, Talk about a regular physical activity program. Focus on cardiovascular risk reduction, which is really the primary cause of death for most people with type 2 diabetes. This gentleman is a smoker, so we're going to want to talk about smoking cessation, and then really focusing on patient-centered microvascular complications. And again, if we tried to do all of this at once, we would not only overwhelm the patient, but you would probably be overwhelmed as well. So when we're looking at managing diabetes, we know that this is psychologically and from a behavior standpoint, one of the hardest diseases to manage. Much of that is because this requires 95% of the care to be self-care. And um, patients need to be able to make major changes in their life so they can move forward with the healthy changes for their diabetes. We also know that traditional healthcare in the United States is focused around symptom-based care and problem-based care. So patients are used to coming in with a problem and having it fixed with an intervention at the time of the visit. They're not necessarily used to being able to come in with a chronic disease and work with you on chronic management, on behavior change, and lifestyle interventions that can help them manage their diabetes better. Further, we know that there are very strong cultural influences in the way that people manage their diabetes or manage their lifestyle. And as you start to make therapeutic lifestyle changes, um, you're going to be not only managing their health beliefs, but also cultural beliefs and social influences. And this may be, in many respects, not only working with the patient, but also with their family. So what about glucose monitoring? We know that glucose monitoring is one way to assess how your diabetes treatment is going. And some recent results have come out to say that your glucose monitoring should really match the intensity of your treatment. So if someone is being managed with lifestyle alone, you might be able to have rare checks or just a couple times a week. If they're taking medicines that are not likely to drop them low, maybe one time a day is enough. However, if they're on insulin secretagogues like sulfonylureas or glenides, or if they're taking insulin, they really need to be monitoring more often. And one of the rules of thumb we use is they really should be monitoring their glucose every time before they take an injection of insulin. And then we want to make sure the insulin regimens make sense in terms of avoiding hypoglycemia. Now, as a note, I will commonly do as we mentioned in this case. When someone's newly diagnosed with diabetes, I may give them a glucometer and recommend that they check their glucose at different times of the day just so they can see how their life affects their diabetes. I find this to be a very effective tool for lifestyle change because people will try things, and if they have good effects on their glucose, they can come back to me and report that these things are beneficial for them. So for example, I'll have a patient to say, did you have any idea that eating sweet potatoes doesn't rise my glucose as high as, per se, eating regular potatoes? Or taking a walk after dinner really can improve my glucose. And when patients are able to report things that they found, they're much more likely to continue them long term. But once we've got a steady pattern, we can adjust to a reasonable frequency of glucose checking that makes sense. So what are the glucose goals? The American Diabetes Association now has recommendations across the age span. So we have a number of different goals, and these really depend on the benefit at that age group, as well as the relative risk of hypoglycemia. So we know that an A1C is one of the common figures that we look at first. In children, we accept a default A1C of below 7%, 7.5%, because we know that the risk of hypoglycemia and the variation in people's lifestyle is great, and that you might need a little bit looser control. For most adults, we have a target A1C below 7%. Older adults, we sometimes have a higher A1C because we know it takes a long time to get benefit from intensive glucose control. And for our sick older adults, particularly those with a limited life expectancy, we might even have an A1C target of below 8.5% because we want to minimize risk because they may not see any benefit from intensive glucose control if they have limited life expectancy. Each of these A1C targets come with a fasting and a bedtime glucose target, as you can see listed there. Most of the time you will see the adults targets as the ones that most people adopt to, with an A1C below 7, fasting glucose between 80 and 130, and then a bedtime glucose less than 180. And while we have a target A1C goal, it is important to know that we do individualize our targets based upon factors of the patient. And so this algorithm from the American Diabetes Association really helps us to decide that. We're going to pick a more stringent target for those people on the left-hand side of the graph and a looser target for those on the right-hand side of the graph. So for example, if I have someone who's at very high risk for hypoglycemia, I might choose a loosened target to reduce that risk. Someone that's had a shorter duration of diabetes, I have more years to protect, I might pick a tighter target. We look at their life expectancy, and to me that's one of the major things I look at to decide. If they have a long life expectancy, I'm more likely to try to achieve aggressive glucose control. And then we also look at comorbidities and vascular complications. And the more complexity there is to their medical care, the looser my guidelines will be, because I want to get as much benefit with a minimal risk. And we mentioned this earlier, but diabetes self-management education and support is critically important for all people with diabetes. This should be started at minimum at diagnosis, but also during key periods of their life when there are changes in their disease, changes in life circumstances, or changes in their medications. Yet, believe it or not, less than 6% of people receive diabetes education and self-management support education in their first year of diabetes. And to me, I liken this to driver's ed. If all of you started just driving without any driver's education, you'd probably figure out how to drive, but there'd be quite a few bumps and bruises along the way. With a disease as serious and as complicated as type 2 diabetes, we really should be strongly encouraging all of our patients to get diabetes education. But there are many reasons why patients don't go. This may be due to cost or a lack of coverage. It might be because of the time it takes, or it might be related to a lack of engagement by the healthcare provider seeing the benefit of that. When you have your patient and they're coming in for a diabetes recheck, there's a bunch of things that you're going to include in your evaluation. Have there been any new medical, social, or economic problems that could affect their ability to manage the disease? Have there been any medication changes by their healthcare team? We find that many people with diabetes have multiple healthcare providers, and this can really complicate the disease, and so we want to make sure we get regular updates, both from the other healthcare providers as well as from our patient. And then we really want to assess how adherent they've been to treatment. The average person with type 2 diabetes will take 7 different medications a day for blood pressure, lipids, and for glucose. And so that's not a small task. And so I actually start from the place of asking my patients how often do they miss their medications rather than how often they take it, because I find that it's a much better way to let patients be honest with me so I can, one, assess what they're taking and what they're not. And that makes it much safer when I'm adjusting their medication rather than trusting by what I prescribe. And then the next few slides are from the 2018 ADA Standards of Care. And in the standards this year, they really put in a very clear description of what's expected for optimal care of people with type 2 diabetes. So you can see here, and I'm not going to read through all of these, what components of the history and physical in terms of past medical history and family history should be included in the initial visit, follow-up visits, and annually. What components of social history, medication, and vaccination should be included. How does the interface with technology become important? What are the important screening tests that we do for diabetes? And then what are the physical exams that are recommended for someone in routine care of diabetes? And then finally, what's the laboratory evaluation that's recommended for people with type 2 diabetes. And so it is worthwhile to have a general overview of the types of things that are done routinely, those things that are only done at diagnosis, and particularly what things are expected to be done annually for people with type 2 diabetes. And then finally, they share with you kind of the what should be part of the comprehensive plan, an assessment and plan when you're seeing your patients with diabetes. And so the guide here is not to be dogmatic about all the things you should do, but to give you guidance about ways to structure your care for the patient with diabetes so that you're providing the best care possible. We mentioned earlier that there are multiple metabolic defects in type 2 diabetes. We talked about the ominous octet. And part of our discovery of the ominous octet is that as we started to discover medications that seem to help manage type 2 diabetes. For each of these pathophysiologic abnormalities in type 2 diabetes, this provides a medical target for which we can treat. And so Dr. Young will be going through the pharmacology of type 2 diabetes and all these medications. But you can see that if we're looking at ways to increase insulin secretion, the sulfonylureas, glinides, DPP4 inhibitors, and GLP-1 receptor agonists all help to increase insulin secretion. If we're looking at circadian rhythms and hunger, bromocriptine is helpful. The best medication to improve skeletal muscle sensitivity are the TZDs. The SGLT2 inhibitors work to reduce glucose reabsorption and increase glucose excretion as a treatment of type 2 diabetes. And we have multiple medications that work via the GI tract. And then when we're looking at hepatic glucose production, metformin is our primary worker to reduce that, but also the incretin agents GLP-1 and DPP4 also help. And then when we're looking at glucagon suppression, we know that the incretins, DPP4 inhibitors, and GLP-1 receptor agonists help to reduce glucagon. I don't expect you to know all of these right now. You will learn these as well from Dr. Young. And I know it sounds a bit like alphabet soup, but as you gain experience with these medications, you will find that they become a bit easier to remember. Now, this is from the 2016, not the 2018 American Diabetes Association Standards of Care, but I find that this is an easier one to project on a slide, so that's why I use this. But in our lab, we'll use the 2018 standards. And for everybody who's been diagnosed with type 2 diabetes, when we look at treatment algorithms, in the kind of teal box around the outside, one of the first steps of treatment of type 2 diabetes is therapeutic lifestyle interventions that improve, that look at improving healthy eating, weight control, and increased physical activity. And this should be part of any treatment plan for every patient with type 2 diabetes. But what's also been added is that in addition to lifestyle, everybody should also be started on metformin at diagnosis. And I'll talk in a couple slides about why that's important. Metformin is the first recommended treatment for type 2 diabetes because it is highly effective. It has a very low cost. It tends to be weight neutral and a low risk for hypoglycemia. And it seems to have some long-term cardiovascular benefits with relatively low risk. Once you move beyond metformin, from the American Diabetes standpoint, you really have a wide range of medications you can choose from, and you can individualize based upon patient factors, whether cost is the main issue, or risk of hypoglycemia, or weight. And so you can actually pick a medication based upon your patient level factors. And then if you need a third agent, again, it shows you the combination of agents you can use. Now, what's written in the smallest print on this slide is actually right here. And what really should be the most important thing in this slide is that every 2 to 3 months, if your patient's not at target, you should be intensifying treatment. And we find that that's not at all what happens typically. We typically will take months to years before we make changes. But diabetes is a progressive disorder and needs a progressive treatment plan. And so if we follow the ADA or the ACEs, American Association of Clinical Endocrinologists, all patients who are uncontrolled would end up being on insulin 1 year after the diagnosis. And if their glucose was high at diagnosis, it might be even earlier. So we really want to talk about timely and intensive treatment for type 2 diabetes. But stepwise treatment is what we see most often. We do see healthcare providers recommending lifestyle first, but they don't always recommend metformin along with lifestyle intervention initially. And typically they'll recommend one medication, and they might be for on an average of 1.8 to 2 years before they intensify to the second medication. At that point, they add a second medication, and they might wait 3 years before they add a third medication. And the problem with this is that diabetes is progressing, but our treatment is not. And so we continue to fall behind the curve. And what I call this is the treat to fail algorithm, where we treat until it's so obvious that our glucose is high that we add another medication. But at that point, we're so far behind, we're not likely to catch up. So if you're going to treat type 2 diabetes, you need to be timely, intensive, and you need to try to stay ahead of the curve. Now here's just one example of the importance of timely intervention. It's already well established that metformin should be the first-line treatment of type 2 diabetes in terms of medication. But a study by J.B. Brown found that even if we wait, what has been very common, but not give metformin at the diagnosis of type 2, but give a chance for lifestyle first. Let's do lifestyle for up to 3 months, and if that doesn't work, we'll add metformin. And what she found was, at the end of 3 months, those people who were started at metformin at the second visit, that metformin worked 12%, or excuse me, had a 21% failure rate versus 12% starting at the first visit, and the durability of it was half as long. So using using metformin early improves not only the efficacy of metformin, but also the durability. And I believe that to be true actually for many medications. So again, you're more likely to have success with a timely intervention. Now we've already talked about lifestyle intervention as being a necessary component. If I'm going to give tips in terms of management of diabetes, lifestyle should be recommended at the initial treatment and then at every treatment thereafter. And you really want to focus on reinforcing whatever behaviors they do and not trying to set the target behavior as the first behavior. So if someone is not active at all and they increase their activity to 5 minutes a day, I'm going to encourage them for doing a nice job of 5 minutes today, and we'll work to 6 minutes per day at the next visit. I also find that you're much better off to start aggressively treating, get ahead of the disease, and rather than doing step-up treatment, do step-down treatment. And step-down treatment allows you to get ahead of the disease, and you find much greater durability of your treatments. We also have good evidence that you could assume about a 1% reduction in A1C for every medication that you give. So if you know the person's initial A1C and you know the target A1C, then you really know what number of medications you need to use to get there. And so if an A1C is 9 and I want to get to 7, I'm going to need a minimum of 2 medications to get there. And if someone is willing to engage in very active therapeutic lifestyle change, I can then use that as part of my equation and say, well, if you're engaging in this much lifestyle change, I'm very likely going to have to back off this other medication. When you're intensifying therapy and the person's out of control, make sure that you never substitute a med by adding one medicine and stopping the other. You always want to add the new agent first, get ahead of the disease, and then subtract the first medication once the person's under control. And then please engage your patients in this decision making. Too many patients feel like they're getting judged when they come to the diabetes office visits, and you want to let them participate actively in what kind of treatments are provided and which medications they can be on, because they probably have strong opinions about what they want to do. And then also make sure that you develop a plan that prevents hypoglycemia. Other things I would recommend. People with diabetes have a complex disease that involves many organ systems. And if we're going to manage diabetes well, it needs to have at least 4 visits per year. I tell people that there's almost 9,000 hours in a year, And diabetes deserves at least one of those hours. And that's really all I'm getting with my patients is 1 hour out of the entire year. And this is a small price to pay for managing a serious and chronic disease. You want to make sure that you address competing agendas. Remember that patients may come in and want to talk about their headache that day, not necessarily about their diabetes. So if we're going to talk about their headache, I'll say, I'm happy to address your problem today, but we'll need to bring you back for a diabetes recheck. Make sure that you celebrate small successes with your patients. They work very hard to get the goals that they're achieving, and you want to make sure you're focusing not only on the product, but also the process to get there. And so I will routinely give patients smiley faces, stars, and other ways to recognize the work they're doing just for doing the work, let alone for achieving the goal. And then remember that diabetes is complicated. It requires a total overhaul of people's lifestyles. And the more touch points you have in that person's care, the better off that person's management's going to be. So please include your team, a team of providers when you're managing diabetes. And that could include clinical pharmacists, nurse educators, dietitians, social work, even community health workers. So know that all of these providers have important roles to help, and you can work in conjunction to manage diabetes. So we talked earlier about the glucose targets in diabetes. And I will, again, as I said, routinely share these with my patients so they know what we're working towards. And when they're checking their glucose, they know whether they're at goal. We also have blood pressure goals, and there are lipid goals. And the lipid goals had changed in 2013. And so we now, I'll go over those goals. So we want to make sure that we're not being only glucose-centric when we're managing diabetes, but thinking about the bigger picture. So a thought question for you. When we have a patient who has type 2 diabetes, who has hypertension, and who has dyslipidemia, when we try to treat those problems, which thing's going to give you the greatest benefit? And if you only had to pick one of those things, glucose, blood pressure, lipids, albumin, which one of the things is going to give you the best benefit if you're getting that to goal? And certainly, under the best of hands, we could say that lifestyle would make a difference, but unfortunately, that's not been a universal response. So we want to really think about blood pressure, glucose, and lipids, treating which of these is going to give you the best mortality benefit. So most physicians in this study and even up to recent days report that they think that getting the glucose to goal is going to give you the greatest mortality benefits. But indeed, this is not true. Someone that has dyslipidemia, hypertension, and hyperglycemia will actually get the best benefit from hypertension treatment and getting the blood pressure to goal. Get the second best benefit from lipid control, and then the third best benefit from glucose control. So while it's important to make sure that we treat the glucose in type 2 diabetes, we want to recognize that the number one cause of death is from cardiovascular disease, and the comorbid diseases of hypertension and dyslipidemia contribute even greater to this mortality. And when we look at the microvascular complications, you can see there's a very nice correlation between A1C level and the risk of complications. So as we lower all the way down to the normal range, we can really reduce the microvascular risk complications. And we've had plenty of evidence for a long period of time that these benefits are present. So how do we do? Do we actually achieve these targets? And I'm sad to say that even in 2018, we're not doing so well. Less than half the patients are meeting the targets for A1C, blood pressure, or lipids. Sometimes we get above 50%, but most of the time we're slightly below 50%. But what's even more important is how often do we get all three targets at once? So we have our patient who's got a blood pressure under control, the lipid under control, and the glucose all under control at the same time. And we're generally below 15%. So we have a long way to go to improve diabetes care. So my last topic is really kind of talking about comprehensive care guidelines. What are the other things we do to help manage our patients with type 2 diabetes? And we have this also listed from the ADA standards. we know that we want to do annual skin exams looking for skin breakdown and evidence of peripheral neuropathy. We're going to do a neurologic exam annually, a dilated eye exam annually, and microalbumin annually looking for neuropathy, retinopathy, and nephropathy. And then we certainly do a cardiac history um, looking for cardiovascular abnormalities and the progression of cardiovascular disease. Um, and so these are things that we would all do at the diagnosis of type 2 diabetes, which is in distinction from type 1, which we typically would wait at least 5 years before we start. And then just some last highlights. It is important to recognize that we need to treat hypertension and diabetes. When we look at the treatment of hypertension, lifestyle can be very effective, and I have a slide to show you that. When we look at medications, we typically use an ACE, which is an angiotensin converting enzyme, or an angiotensin receptor blocker. And we want to typically start that medication when they're hypertensive or if they have albuminuria. We would not start that medication if one of those two conditions are not present because there's no benefit. And when we start those medications, we can commonly see an increase in creatinine. The second agent that use after an ACE or an ARB can be any one of your choice. It really doesn't matter. It's the most important thing is getting the blood pressure to goal and making sure that your second agent is probably dosed at a different time of the day than your first agent. We like to dose one medication in the morning, one medication at night. And then the last tidbit is to remember that you probably don't need to use an ACE and an ARB in combination. There's really no benefit from combining two agents that affect the renin-angiotensin system, and it might actually increase end-stage renal disease. When we're looking at therapeutic lifestyle changes for hypertension, you can see that all of these have really significant reductions in blood pressure, and they really should be considered when we're looking at the management of hypertension in type 2 diabetes. Next, we'll talk about dyslipidemia. Just so you might, as many of you might still see this in some of your board review books, the old ATP3 cholesterol guidelines set lipid values for diabetes. And the ADA continued these until, I believe, 2015, at which they switched over to the American College of Cardiology guidelines. So it's good to be familiar with these, although these are not the guidelines that we use currently. But backed on ATP3, we recommended that people with type 2 diabetes get an LDL cholesterol below 100. If they had known cardiovascular disease, the LDL should be below 50. The HDL should be above 40 in men and above 50 in women, and the triglycerides below 150. With the evidence that statins provide a pleiotropic benefit even beyond the drop in cholesterol, this was seen in the TROPHY study in the Jupiter trial. The Jupiter trial, the recommendation from the American College of Cardiology said, look at the person's risk and decide what type of statin you're going to use rather than focusing on a number itself. So here are the American College of Cardiology guidelines. If somebody is below the age of 40 and they have no risk factors, they probably don't need a statin. When we look at our patients with type 2 diabetes, the great majority fall to the moderate to high range. So they probably, all of our patients with type 2 diabetes have atherosclerotic cardiovascular risk factors. And so I'm going to be using a moderate to high intensity statin in the great majority of my patients with type 2 and some of my patients with type 1. And type 1, as they get older, I'm more likely to use it. And this graph is really meant to just be a reference for you to know what are the low, moderate, and high intensity statins. And so in the light blue are your moderate intensity statins, and in the red are the high intensity statins. And I'm a simple guy, and I typically don't want to have to remember too many things. So I will most commonly use a high intensity statin for the great majority of our patients with type 2 diabetes because I know that I'm going to get them to goal levels. So what's new in 2018? All the rage right now is that there is evidence that there are a number of medications that not only lower glucose, but actually provide cardiovascular benefit. Um, so these include metformin, which we saw in the UK PDS trial, that those people who were overweight and obese got incremental long-term cardiovascular risk reduction. And recently, with prospective cardiovascular trials, we've seen uh, two SGL2 inhibitors, empagliflozin and canagliflozin, and two GLP-1 receptor agonists, liraglutide and semaglutide, that have shown to be independently ability to lower your risk of cardiovascular outcomes. And both empagliflozin and liraglutide have FDA indications to reduce cardiovascular risk. And that is a big change because we often considered medications to be neutral or maybe even high risk for cardiovascular benefit in diabetes. And then finally, there's a patch sensor, the Freestyle Libre, that has just been released in the United States in the last 6 months that would allow people to wear this patch and have continuous glucose readings that they can see on a monitor. This has the potential of really reducing the number of finger sticks or even the use of finger sticks in type 2 diabetes. So stay tuned. It's not commonplace yet, but it has real potential of being a benefit in the future. So all of this comprehensive diabetes management, does it make a difference? Does it work? So I'm going to highlight that in the last few slides. So when we look at the ABCs of diabetes control, A being A1C or glycemic control, B being blood pressure control, and C being cholesterol control, we see very substantial benefit from reduction of each of these cardiovascular risk factors and microvascular. So for every 1% you lower the A1C, you can reduce microvascular complications by 40%. If you reduce the blood pressure, you really get substantial reduction in cardiovascular risk, anywhere from 33 to 50%. And you also get benefit in microvascular risk reduction. And then finally, with lipid control, with the use of statins, you can reduce cardiovascular complications by anywhere from 20 to 50%. And most of these are just for your reference. These are not things I necessarily need you to remember, but the original UK PDS study was the first major trial to show that intensive glucose control had any benefit at all. So when I was a student, I would have professors tell me that we're not sure treating the glucose had any benefit for people in terms of their complications or their risks. But the UK PDS trial was the first to show that in type 2 diabetes. So you can see here that getting an A1C down to 7% as opposed to 7.9% in people newly diagnosed with type 2 diabetes reduced any diabetes-related endpoint by 12%, microvascular complications by 25%, retinopathy by 29%, cataracts by 24%, and a non-significant 16% reduction in myocardial infarctions. And we were a little bit surprised by that because we kind of thought of these people as being high cardiovascular risk. But there were other trials that found similar findings. Remember, the DCCT was a type 1 trial. Kumamoto was a type 2 trial, and you can see also a substantial reduction in retinopathy and nephropathy, an improvement in neuropathy, but no reduction in the short term in macrovascular disease in any of these studies. And the question was, well, maybe they really didn't help macrovascular disease, which is the most common cause of death in type 2 diabetes. But luckily, some of these studies continued at the end of the intervention period and had an observational follow-up period. So the UK PDS did a 10-year observational follow-up. So we know the separation in A1C was 7.9 to 7.1% at the end of the UK PDS trial. At the end of the trial, the patients were set free to go on to regular care, but they reported annually back to the study. And at the end of 10 years after the initial study, they started to see a change in the benefits from the initial intensive glucose control. So you can still see that at 10 years later, they had a 9% reduction on any diabetes-related endpoint. That 15% reduction in cardiovascular infection, cardiovascular myocardial infarction, now is statistically significant, and a substantial reduction in death. And these benefits were even greater in overweight patients who were taking metformin. And so this was really important because we had mixed studies coming out at the same time. The ACCORD study, the ADVANCE study, and the VA diabetes trial that really were not showing any cardiovascular benefit. But what we've learned is that in type 2 diabetes, there is a legacy effect, that you can get a reduction in microvascular complications early in the course of this treatment, but it takes years to maybe even decades to get benefit from the cardiovascular system. So then overall, with the last 30 years of intensive glucose control, have we made any progress in the reduction of complications? And the answer is an overwhelming yes. In a recent publication in New England Journal of Medicine, they showed that with the improvement in diabetes treatments over the last 30 years, we've reduced diabetes-related myocardial infarctions by 67%, death from hyperglycemic crisis by 64%, stroke by 53%, amputations by 53%, and end-stage renal disease requiring dialysis by 28%. So this is really great news for the individual with type 2 diabetes. The unfortunate thing is that we've had such an overwhelming growth in type 2 diabetes that we're getting more and more people diagnosed with diabetes, that although we're making benefits or progress in the individual level, we're still having more people with these complications because of the astounding growth in total numbers of diabetes. So I think that's it. I have some readings for you. The abridged standards of care, the total diabetes standards of care is a very long document. And if you're a budding endocrinologist, you're welcome to read it. I serve on a committee that puts together the abridged standards of care. So it takes that 100-page document and takes it down to about 16 pages. So if you want the cliff notes for the standards of care that get published every year, you can see them at this website. And these are the American Diabetes Association standards. Ralph DeFranzo wrote, as I talked about earlier, a very provocative paper about the pathophysiology of type 2 diabetes, and the CDC puts annual updates on the diabetes statistics. Some optional reading that you can look at is the bigger standards of care, and then we've published 2 different papers related to diabetes. One was an osteopathic approach to type 2 diabetes, and the other was the use of osteopathic structural diagnosis and OMT in the management of type 2 diabetes. I appreciate your attention for this very long lecture, and we look forward to working with you. Thank you so much. Have a great night.